welcome you all to join the next session about the scar. It's about not all scar are the same as we know, right? Rethinking the treatment strategy. I'm Dr. Suparut from Bangkok, Thailand, and
And I'm Neve Corder from Australia. And as a plastic surgeon who creates a lot of scars, I'll be interested to see what the answer is. So we're going to start with Dr. Go, please.
please.
Dr. Go?
Professor Go, are you here? Yes. He went to the toilet.
Oh. So should we start with the next speaker? Is how hard? Can we?
Dr. Kim.
Dr. Kim.
Jong
He's here.
Seo.
Can we load his slides, please?
Could you be first?
Yeah, you can be first. Oh, here he is.
Professor, the legendary Professor Go, please. With the topic of classification of scar and an approach to their management. Please welcome.
Yeah.
You don't want it, right?
Thank you very much. Good afternoon, ladies and gentlemen. And it's a pleasure to be back in Bangkok again. I'm going to talk about the classifications and of scars and briefly about the management, because I think it is something which is not so easy to manage. It's a very challenging condition to treat scars, and they are so diverse in their appearance, and the approach to different scars actually requires different methods of doing so. So scar formation, as you know, is an inevitable consequence following wound injury. Any injury will have a scar, all right? And it depends on how deep the wound is. If the wound is very superficial, then it tends to heal very well. And the deeper wounds are usually worse. And there are many ways of classifying scar, and yet we need to do it because the management of each individual scars are quite different. I'll go through that very quickly later on. And the International Advisory Panel on Scar Management, there's a group of specialists that looks after scars, come up with the recommendation of how you should describe scar, and they include things like immature scar, linear scar, widespread scars, hypertrophic scars, keloidal scars, and so on and so forth, which all of you are very familiar with. And it has got an implication, as I mentioned earlier on, in the way that you manage patients. For example, immature scar are more prone to develop hypertrophic scar and develop keloid if you stimulate to cause irritation to the scar without treating it very early. Scar is usually the marks that's left behind after a wound, as you have mentioned earlier on. And it can be just a fine line or a small tiny pitted hole on the skin, and may be very inconsequential to the patient, but to some patients, but very troublesome to others. And the histology is that you have actually condensation of the collagen tissue, and then the orientation of tissue becomes abnormal. And during repair, the body cannot repair as well as what other organs can repair themselves. For example, the liver, you take out half of the liver, in a few months' time, the liver will just grow back and it's perfectly normal. Whereas for the skin, we are not perfected yet. We can't repair ourselves to become a normal skin. And if you do a skin biopsy, you'll see the orientation of the fibrous tissues as the blood vessels becomes a right angle to each other. So following injuries, the skin will try to repair itself, and when there's excessive repair mechanism, fibrosis will set in, and that's where you start to get abnormality of the skin textures. And we usually divide our scars into hypertrophic scars and atrophic scars. And as you know, the management is very different. Atrophic scars are those scars that you very commonly see in acne, following acne inflammation, whereas hypertrophic scars are very often caused by deep thermal injury that damage the skin. So they can be discolored, as we have mentioned earlier on, and some of this area have caused lax because of the destruction. You don't have hair growth, and in some area it may become important, especially when it scars on the area of the hair-bearing area, that is scalp, for example. And they can be very itchy in some patients, especially keloidal scar, and it can be very intensive, the itch, that the patient have problems sleeping. And we have to provide treatment for all these patients rather than to just push them aside that it's just a scar. So initially, as you all are very conscious of it, they are red, and we see a lot of red lesions in the beginning, especially acne scars, the macular erythema we all talk about all the time, and we have post-inflammatory hyperpigmentations, and sometimes you can develop contractures and all that. And I just wonder whether the so-called redness that you see in a very superficial macular scars or acne, do you call them a scar at all even or not? And whether you need to treat them or not. It costs a fortune to treat acne. Everybody with redness, the whole country's economic budget will already go to treat the acne scars with the redness. And if you leave them alone, invariably they will heal after 3 to 6 months generally. And I'm not very sure whether we should pursue on. But then we also do not know whether by treating this redness that we can reduce atrophic scar later on, whether we will progress with atrophic scar. And so if you are very rich, I suppose you can undergo the treatment. But remember of the other disfigurements and the movement contractibility of the wound that can result from non-treatment of acne scar. The signs and symptoms, I think you are all very familiar with it. It depends on the type of injury, and therefore it's important to get a very good history of what the patient, how the patient acquired the scar. If you know the scar is very superficial, then the chance of scarring is much less. And wound care becomes very important also because, again, it depends on whether there are secondary infections or some underlying mechanism that promotes scar formation. So what I'm trying to say is that maybe we are too late in treating scars. We always think of a scar that is already developed and then let's treat. I think the scar, the management of scars should start the moment you see the patient and you are preparing to treat something. I want to excise an epidermolysis. I want to do some laser treatment to remove the scar. Before that, you must plan ahead. Are you prone to acne? To scars? Are you prone to PIH? Are you prone? And then we should prepare that in the process just before the treatment and during the treatment process as well. And we should change the paradigm in the way we treat patients. And this applies to things like post-inflammatory hyperpigmentation. We should preempt it and then treat. And people who are high risk, we should treat them more aggressively. So classically, scars are flat if it is very mild and generally covers only the epidermis. And they usually become a bit red and become lighter after a period of a few months, and then it will recover completely with very little textural changes. And so these are scars that you want to keep clean and treat as soon as possible when you see them. Then we go to this big bar of hypertrophic scar, and there are two types of hypertrophic scars. Where one is non-keloidal, is literally a scar that has overgrown in collagen, in fibrosis, and you get a tough, indurated papilla raised plaque or papules. And these are due to excessive production of collagen, and we don't know why some people are more prone to it, but we know that if you have got a deeper injury, your risk of developing hypertrophic scar is much higher than if the wound is very superficial, and therefore you must be more aggressive in treating a deep wound and likely to cause hypertrophic scar. And keloid, as you know, is a form of hypertrophic scar that grows beyond the margin and proliferate outside the margin of the injury. And it's actually, if you think very carefully, it's like cancer basically, except that this cancer is confined to only a very localized area. And maybe we should treat it in such a way too, with some cytotoxic drug like 5-FU that we have been treating. But we have always treated them as with intralesional Kenacort injections. So I think we need a paradigm shift. Because if you do a serious histology, you'll find that there's non-stop proliferations of the fibroblasts that cause deposition of collagen, and then you get a new layer form and you get a lesion. The moment you excise it, they just grow back again, and therefore I think we should think of a better way of treating keloid. And they are usually very itchy. Now we go to the other big group, which is the atrophic scar, and generally we see this in acne vulgaris. And I think this is the most difficult scars to treat. I mean, if you have a lot of acne scar, I've never come across a patient with acne scar whom have undergone all the treatment, fractional lasers, hybrid lasers, and radio frequency, has come to hug me and say, "You have done such a wonderful job of my acne scar," because the scar never clear completely. They always have got residual scar behind, and you do all the combination treatment, you can't get. And in acne scar, you have the various type of description, and box scar, as you can see over here, ice pick scars, you have got rolling scars, and each one of them has got their own pathology, and their way to approach is very, very different. And you need combination treatment to get rid of some of this scar. And like Dr. Cheng has mentioned, never promise the patient that I can get you better. Just say I can get you the scars more superficial, but it will still be there. You will need many treatment, many years of treatment and repeated treatment to get some result, not complete clearance as well. So before I just go on atrophic scar, I just want to mention about contractures again, because in a very severe thermal injury, deep injury, you will get contractures, especially if the scars is a burn, especially when you have got scars that right across the joint, like your cubital fossa or your popliteal fossa, then you're going to get contractures, and these contractures can be very severe, that is functionally affect you. In other words, you can't do your work properly because of the contracture. And all this information, you should make use of it to treat the patient very aggressively, like giving them intralesional Kenacort injection very early, and then make sure to do physiotherapy very, very early, and be very intense about it, get the patient to do so. So this is important in hypertrophic scar, or if you suspect the patient is going to develop hypertrophic scar, or even keloids, and this is something that you need to know. So these are atrophic scar that we are all very familiar with. Somebody has shown this picture earlier on. This is described by Jacob and a group of dermatologists on the types of acne scar that can present to you when they come to you. And I just mentioned earlier on that in terms of recovery or improvement, it is very, very unpredictable and not very satisfying. So we have ice pick scar where there's a lot of fibrosis right at the end of the tip of the lesion. And then we have box scar, which is a round, depressed area. And then we have what we call a rolling scar, where the fibrosis is across the whole dermal area and sort of pull the scar down. So I think we need to know about the risk of scar formation in the management of scar, which I've mentioned
Professor
earlier on.
Goh?
You should go. Yeah, I'm going to finish. Yeah. So this is something that you have to think about. So here are some features that you got to observe when you see the wound and all that, and from there you can then manage the patient and prevent. And I won't go into detail because there's some information about lasers, which the other speakers has spoken about. Thank you very much.
We save the question for the last. Okay, next speaker will be Dr. Kim Jong-seo with the very interesting topic: needle-free implantation of decellulized micronized human dermal for treating stretch mark and facial scar, a true dermal graft, not a collagen stimulator. Please.
I'm very happy to be here with my expert doctors, and then in this beautiful room. My name is Jung-seo Kim from Korea. I'm a plastic surgeon. For many years, the aesthetic medicine, the scar, is focused on the stimulating the collagen inside. But why should we wait for the collagen form? So why not simply replace the missing dermis using the dermis? Right? The simple idea is led us to a new concept, the injecting dermis to the dermis. The acne scar is required a highly targeted treatment, so I realized the need for the more precise and specialized the needle-free injector. This result demonstrate the consistent injection depth. This confirms that the needle-free injector can offer the precise delivery. So I investigate the depth of after injection using the sonography. This name is the CureJet can consistently deliver the CAHA particle at the uniform depth. This is video showing the treatment abdominal stretch mark scar being treated with the CAHA particle, hyper-diluted CAHA particle. It is very accurate and very fast. This is a before and after photo, the stretch mark treatment using CAHA. Right side, here is the immediately after the treatment. We needed the downtime for 1 week. The ultrasound confirmed that the upper dermis, you can see the white dot, CAHA is accurately delivery into the constant depth in the dermis. The mean depth was 0.53 millimeter exactly in the dummies. Next, I would like to introduce the needle-free injector and CAHA using the acne scar. For evaluation, first I using the ultrasound, using the scar depth, and then second I using the 3D analysis to using the skin surface. Now I'm injecting one by one for the scar, depressed acne scar, using the contact mode. There's many ice pick scar, box scar. One by one, I inject CAHA particle into the dummies. The depth was about 0.5 millimeter. And then I inject spray mode. The recovery time needed 3 or 7 days. The traditional subcision is time consuming to release the scar, and then that is highly operator dependent. In contrast, the needle-free injection, needle-free subcision is faster, more consistent, and treat wider area with a greater precision. You can see the CAHA particle upon the dummies. The ultrasound clearly demonstrate the successful lateral subcision of the acne scar. This is a very high resolution of ultrasound. It's so expensive, but I bought it. Ultrasound confirmed the precise and consistent delivery. CAHA particle, in this case, depth was 0.7. Depend on the patient, depend on the scar, depth was a little bit changed. This upper is, you can see the depressed scar. Below is immediate treatment. You can see the subcision and then elevate the scar immediately. The visible improvement was observed in both the enlarged pore treatment and the acne scar. The clinical score in this program improved 26 to 21. 23 patients is I study about this study using the skin roughness and ultrasound. So this is result. The acne scar is improved a lot after the CAHA treatment using needle-free injector. You can see the before and after. Acne scar improved. Active acne improved. The inflammation improved. Keloid scar also improved all. It's an amazing result. He suffered from the recurrence of the acne for a long time, but why the active acne never recur back? The hypothesis is that the needle-free injection and the CAHA particle stimulate the skin regeneration, and then maybe it can stimulate the stem cell marker, and then that can make skin rejuvenation and remodeling. Another case, I using the contact mode one by one, using CAHA particle, and then I spray mode into the whole face, 20 shots per second. This is very fast. This immediately after injection, I inject 30,000 shots for 5 minutes. Also, this patient showing injection depth was 0.3. And then lateral subcision was 0.4 millimeter. This is immediately after treatment using CAHA, using needle-free injector, before and after, scar improved, and then acne scar also improved, box scar and ice pick scar was improved a lot. And then the main topic, injecting dummies into the dummies. This is the paradigm shifting. The ADM product, acellular dermal matrix, the new product name is Re2Fine, is the micronized ADM powder with a particle size of 50 micrometer. It is very small particle. It is good for inject, needle-free injector. The overall skin improved. Now I injecting the spray mode for whole face for the improvement of skin pores. ADM distributed very fastly, 20 shots per second in whole face. And then I inject one by one the contact mode for the acne scar. Yeah. This create subcision and then replacement at the same time. It is just more than injection, it's the dermal graft, dermis graft. We are placing real dermis into the damaged, depressed dermal tissue like this. This is immediately after the scar is released through the needle-free injection. The ADM powder is simultaneously implanted. So it is a concept is two, subcision and then skin transplantation. Right? This is after the treatment, the result is amazing. Unlike the collagen, the stimulator, there is no need to wait a month for the neocollagenesis. This benefit is immediate. The scar is released, the space is restored, and then ADM is implanted at the same time. This combination provides a result that are difficult to achieve with the conventional acne scar treatment. Left side, this is immediately after treatment. This technique represents the fundamentally different approach to the acne scar treatment. The traditional therapy rely on the body to regenerate and then make new collagen, and then we need to wait a month or few months. In contrast, the needle-free subcision with ADM implantation provide the fast correction, while we can make amazing result like this. The scar is released, space restored, dermis is replaced. There's no need to wait collagen stimulation. And combining mechanical scar release with needle-free injection, and then at the same time we can implantation. This is more than scar treatment. It is dermal reconstruction, not collagen. Yeah, the collagen stimulation, dermal replacement. This is why I believe the ADM treatment is good for the acne scar. Thank you for your attention.
So this person will be speak the latest?
Yes.
So you can introduce.
You'd like the platform?
Okay, you can use this and the hand mic.
So let me introduce Dr. Gupta, who is going to speak to us on microneedling and microneedle fractional RF in the attenuation of atrophic scars. Thank you.
Thank you so much. And I'm going to speak to you about something that I do often and something that has been an established treatment for scars. I want to show you my results. This is a combination of microneedling, manual microneedling, microneedling radiofractional with other combinations in the improvement of atrophic scarring. Now, this is typically what I use, and I will show you results with this. Subcision, obviously everybody uses it. Talking about needle-free injectors, I have used something called the jet volumetric remodeling, which is nothing but, again, needle-free injection of a biostimulatory particle or HA into the dermis. Chemical peels for macular scarring, we do a lot of Q-switch lasers for, again, pigmented shallow scars, manual microneedling, and microneedling RF. Let's come to acne scars. So these are just, I'm going to show you some of my results. I think most of you understand that over a period of time, scars improve. This is only 4 sessions of microneedling radiofrequency. I use a bipolar microneedling radiofrequency. It's an established treatment. This is the front face of the same patient. And this is only 2 sessions of just microneedling radiofrequency. And you can see that this is a great modality in darker skin. RF is colorblind and so very safe, and it's a doable procedure. Let me show you these scars. Again, this is a combination treatment now. Initially, I go deeper, treat with 4 sessions of microneedling radiofrequency, and then follow it up for superficial resurfacing a little bit with manual microneedling. I use something called the Dermapen with drug delivery of retinol, and you're able to achieve this. This is the other side of the same patient. Again, a good improvement in my understanding. So this is what I did. This is the forehead. 4 sessions of microneedle radiofrequency, space them apart, 4 to 6 weeks apart, followed by 2 sessions of Dermapen, 4 weeks apart. So you always space them long apart for the collagen to build. This is just 2 sessions of microneedle radiofrequency, 6 weeks apart. So we do see these kind of results. Again, this is something that I want to reiterate, and we know this. We can use oral isotretinoin with all these procedures unless it is traditionally ablative. So safe with microneedle radiofrequency, fractional lasers, non-ablative, ablative. This is oral isotretinoin ongoing with 4 sessions of microneedle radiofrequency, 6 to 8 weeks apart. And this is the other side of the same patient. Again, ongoing isotretinoin. Wanted to show you this. This is a little bit different. Again, very mild scarring. But people do come to us for pores, for texture improvement. And I love to give topical tretinoin. It is a great collagen remodeler. So you give it at home. You can use a low concentration, 0.025% is what I use, maybe alternate night, carefully, and 3 sessions of microneedling RF. This is the other side of the same patient. And of course, they break out again and again. This is, again, just topical tretinoin. I just want to highlight these very superficial, like Dr. Go said, macular erythematous scars, but they do very well with topical applications and microneedling. This is a middle-aged patient with more laxity. So again, I was able to achieve this. This is first session. This is second session. This is just microneedle radiofrequency fractional. And somehow this was a little bit better because I went in deeper. I did 3 to 4 passes with a lot of downtime, like 4 days, 5 days, but I was able to achieve this. Sometimes you get gratifying results, sometimes you don't. This is what you see more often, and these are buck scar, deep scars, and they require subcision. I do both needle and cannula. This is a needle subcision. First subcise them, release the scars, then a couple of sessions of microneedle radiofrequency fractional. This is 6 to 8 weeks apart, as you can see. This is another patient, just 1 session of subcision and your good old microneedle radiofrequency fractional. I do agree we have better methods of subcision these days, but this is what works traditionally. Yes, I want to show you this. This is a photo damage patient. She's a pilot. She had a lot of photo damage, and as you can see, like a lot of dyschromia, a lot of pigmented scars. And this is the result, and I'll show you what do you do for this. I used a nanosecond device, multiple sessions of 1064 nanometer, which is safe in the skin color, Q-switch Nd:YAG lasers, and 4 sessions of microneedle radiofrequency fractional. We do understand that even Q-switch laser toning somehow remodels scar, although we know for now that pico lasers are a little better with scars as compared to the nano lasers. Peels. Active acne, you can combine peels. Salicylic acid 30% is something that I love. This is multiple sessions and 8 sessions of microneedle fractional. Baseline, post 4 sessions, post 8 sessions. So this is how Again, another case, 4 sessions of microneedle fractional and 2 sessions of Dermapen, rolling scars over here. So this patient did well. She had been, and again, some Q-switch TAG lasers for the freckling, etc. Over 2 to 3 years. I do agree, sometimes it really takes a lot of hand-holding, and so this is what I did. This is the protocol for this patient, and this is similar. I'm just going to skip through. Yes, I want to talk about this. These are difficult. Deep, punched out, difficult scars on the shoulder. I lost the patient to follow-up, so I just have one picture, but I did do the needle-free injector. I used to use something called the jet volumetric remodeling, which is nothing but a high-propulsion device which can push in non-cross-linked HA or any other biostimulator and induce a liquid subcision, and you can, obviously, you have the effect of the filler. And this is microneedle radiofrequency fractionals. I'm just telling you my combinations with microneedle. Open pores, we do understand this. Just going to skip through this quickly. Open pores, open pores. We discussed that it helps with sebogenesis. So it's good for sebogenesis. Self-harm scars, I want to show you this. Yeah, I had a patient who was very young, full 4 limbs mutilated. So this is I want to show you the pictures of the upper limb. This is all the upper limb, and I'm sorry, this was how the thigh area looked when the patient came to me, and this was all over the lower limbs. So this was full upper limbs and full lower limbs, young girl. And when you see up close in this, you do see post-inflammatory hyperpigmentation, but you also see indent. So you have to now treat both. So it does seem like it's just hyperpigmentation, but there's indentation when you look up close. Takes time. This is the result that I got over time, still undergoing treatment. But I want to show you this. So this is treated with topical tretinoin, 0.025% at home, twice weekly at night, glycolic acid 6%, twice weekly at night, 4 sessions of microneedling RF, and 3 sessions of Dermapen. This is what I was able to deliver. Again, she's still undergoing treatment. So this is what I already told. This is a slightly close-up view at this other side of the same patient quickly, and the close-up. Now, if you look up close, yes, you will see the atrophic scarring recovering, and I believe that the assisted delivery with Dermapen, with retinol, and basically the topical tretinoin at home worked really well. Striae, you can treat it. I use I use jet volumetric remodeling, like Dr. Kim said before. Needle-free injectors are good. I don't have that device, but I tried this. Again, hyaluronic acid causing liquid subcision and 2 sessions of microneedle fractional. Jet volumetric remodeling with non-cross-linked HA, 2 sessions, 4 weeks apart, followed by 2 sessions of microneedling fractional, 6 weeks apart. Striae, we see it, not the most perfect result, I agree, but topical tretinoin and microneedle radiofrequency fractionals, there's a little PIH, it's darkening up the area, it's always hard to treat, very hard to treat, in my hands at least. This is slightly better. This is slightly better, I would say. 2 sessions of microneedle fractional, I immediately applied a tretinoin or a retinol peel over the radiofrequency treated area, left it on for 6 to 8 hours. There is some downtime, but slowly, again, the patient wasn't patient enough, so I lost this one to follow up also. So this is what I did. Tretinoin peel, like you can see, 6 to 8 hours, leave on. Traumatic scars, I want to show some of this. This is subcision plus MNRF. This is the protocol, 4 to 6 equals 2 subcisions and 3 MNRF. If I go back on this is a candidate for surgical revision. I don't do as much surgical revision. This is what I had in my hand. And I did a cannula subcision, and I did microneedle radiofrequency fractional. I want to show you this. This is one of my
Dr.
difficult
Gupta?
cases. This is a,
Dr. Gupta?
yes, I'll just wind up. My last slide. Yes, so this is a glass cut, as you can see, on the forehead. Very difficult, and again, hard. This is 2 sessions of Dermapen, deep subcision with the needle I did, and of course, it got lifted. And this is 1 subcision, 2 sessions of Dermapen, and 4 sessions of Dermapen, and 2. That's an ongoing treatment.
Thank you.
Yes, I'm just winding up, finishing. I think varicella, I just want to show this. This is
We're up for time, actually.
Yes,
Thank
yes,
you.
I'm
Yes.
finishing. 2 dermapen, 1 subcision. I will close. Thank you.
Thank you. Thank you very much. So last, I'd like to invite Dr. Colley, please, to talk to us on her multimodal approach to treating hypertrophic scars. Thank you, Dr. Colley.
Do you need to use this or? Yeah, I need this. I need this too. I thought wearing high heels was good enough, but I'm glad to be elevated. So I can get a better view of the chairpersons as well as all of you. Great to be in a full hall, and thank you for being here. Well, multimodal approach to treating hypertrophic scars is not new, but what I decided to do was to take one scar and do different modalities on that one scar, because this patient came with it, which was a challenge. And I thought, let me just see how I can evolve in treating this scar and take it forward and see how it will work for her. And this was a thought process I had. So here we go with the case. She was a young 24-year-old, known to have keloidal tendency, and she presented with this keloid on her cheek post an episode of nodulocystic acne. So this was a really bad nodulocystic lesion. She showed me a photograph of it, and she had treated it with topicals and some orals, and she came to me at this end stage and said, "Doc, I need to get rid of this," and obviously it was plump in the middle of her cheek. So I took a dermoscopy. I use my dermoscopy all the time. Sometimes it tells me to buy a little time to put my thinking cap on. Sometimes it tells me inside what's going on, which maybe the eye doesn't see. And it also helps to plan out your patients a little better, or you're looking for something more than just what meets the eye. And here is the dermoscopic image. You can see there's clearly vascularity as well as hypertrophic tissue. So I thought, we always use intralesional steroid for such cases. I use 2.5 milligram per ml of triamcinolone acetonide. I injected her twice, 1 month apart, and in the lesion. And perilesionally, I used toxin, BTXA, and I used it in a dilution, being plumb on the cheek where the zygomaticus major is. I used 1:4 dilution. I used only 4 units of this dilution perilesionally. So here we injected the intralesional in the center of the scar, and around it we injected the toxin in 4 quadrants. A small amount, as being very conservative. In the second session, I put 6 units because after the first session, I knew I was safe. And then this is how she progressed. And we found that her scar had flattened significantly, and you could, but however, see that there are a lot of milia. Okay, so we said, okay, this is the scar now. You can see it's flattened after 2 sessions, and this is the advantage of adding toxin to intralesional steroids. It improves the softness of the tissue, the color of the tissue, the flattening is superior, and the results last longer. This synergy itself I have found very useful. I've been doing this since 2009 on the face, body, shoulder, traumatic scars, accident scars, all types of scars. Now I decided to, and you can see over here that the scar is clearly vascular with arborization. You can also see disorganized collagen over there. So I first removed all those milia, and after removing the milia, I called her back a week later, and we decided to do something for the vascularity first. So we used our Alma Harmony SR probe. We cut a template in white paper to match the size of the scar so that the energy is only delivered over the scar and not the surrounding tissue. And we used 5 to 6 joules, between 5 and 6. 2 passes. First time was 5, 2 passes, and next time I moved to 6. And we did this 3 weeks apart, 3 sessions. And this you can see now, after that, this scar has become visibly better because the vascularity is so much better organized. And you can also see that the collagen is also looking more organized. So we were trying to remodel the scar tissue. Being on the face, I didn't want to be too aggressive with an ablative laser or trying obviously not to excise it, that was obvious, but also not to be too aggressive because you cannot be with a scar. And then we decided why not now work on the collagen further. So we decided to do fractional skin resurfacing using RF. This is a device that ablates 10% and it has non-ablative for 90% of its energy delivery. And this is what we found even after just one session. This scar became like this, and this one, you can see the dermoscopy has distinctly improved. The scar is looking much more remodeled, much flatter, and much more acceptable to the patient. So, what was the whole rationale? The rationale was that intralesional steroids reduces fibroblastic activity, inhibits collagen synthesis, and reduces inflammation and symptoms in a scar. She was feeling a bit irritable over it, and she was trying to cover it up with makeup and obviously not succeeding and handling it a bit, so all of that came down. The toxin decreases mechanical tension at the scar site, reduces fibroblast proliferation, and it also helps with the TGF beta-1 expression. The fractional skin resurfacing with RF broke down abnormal collagen, promotes neocollagenesis and elastin production for textural improvement, and reduce the thickness of the scar. So, combined therapy may achieve better aesthetic and symptomatic outcomes, both of which are important in scars, in fewer sessions. So, you saw we did 2 sessions of ILS and toxin. We moved on to do 4 sessions of the IPL, and then we moved on to do 3 sessions of fractional skin resurfacing, and all this took place 3 weeks apart or 2 weeks apart, and that's how we ended up giving her a result in 4 months. So this was how she started, and in 4 months, this is how she looked, and she was extremely happy, so were we. There's still that one lurking milia. We would remove that, and we continued to do more sessions of fractional skin resurfacing with RF. We won't do more than 4, very low energy and very low wattage, just for stimulation, not to ablate, not to be aggressive. And I think finally, we will end up with either a booster or to stimulate some more collagenesis as well as to improve the texture, or maybe we may end up doing a filler, is probably the last part of the journey to give her as good a blend as is physically possible and give her the best outcome and also have a happy patient. Thank you.
Thank you very much. And thank you for keeping to time. Much appreciated. Now, have we got anybody else? No?
Actually, we have one more doctors, but Dr. Nasha,
She's still not here?
she's not coming. So I think it's time for Q&A.
Yeah.
Please.
Any questions? Yes.
Dr.
Fantastic.
Noda.
Thank you, Dr. Yeah, I'm Dr. Shinji Noda from Japan. I have a question for Dr. Gupta, especially for the tretinoin use. Do you use topical tretinoin only for pigmentation kind of improvement, or also do you use that for atrophic acne scar? Because the tretinoin has some evidence saying it can restore the collagen in the dermis. So
I definitely use it for the scarring component also, because we know that retinol causes neocollagenesis. Based on that principle, as much as you can add in terms of, not causing local irritation, keeping it twice weekly at night, short contact, or thrice weekly at night, giving a gap after the treatment. So I use it both for post-inflammatory hyperpigmentation as well as for scarring. But in my understanding, it really works well for scarring.
you also had a good result with Dermapen when I used the tretinoin together. So I asked about the question. Thank you.
Thank you.
So, is this question behind you first? Sorry.
Thank you so much. My name is Steven. Is this on? Okay. I want to ask you about regarding the use of microneedle radiofrequency and the Dermapen, consequently, right? So, and what do you think is the advantage of Dermapen compared to the microneedle radiofrequency? Why don't we just use the microneedle frequency through and through and just forget about the Dermapen?
Absolutely, very good question. I introduced the Dermapen later in my practice. I mean, I had the microneedle radiofrequency first. The advantage is microneedle radiofrequency a little deeper, I think that Dermapen causes a better superficial resurfacing. Also, you can do drug delivery. You know, at least with my device, with MNRF, I couldn't do drug delivery. I do understand that also Dermapen is a less painful treatment, practically. Microneedling radiofrequency, a lot of devices are, the traditional devices are painful. So this is what I did, that I tried to combine, but yes, I do agree with you. You can go, I had some cases with just microneedle radiofrequency or just Dermapen, but yes, I do feel once you tackle the deeper component, then you can come up superficially and do it with Dermapen.
Well, but you can also use a microneedle radiofrequency and just, you know, make it more shallow, right?
Yes, you can. Absolutely, you can. But that's what I'm saying, that this is just my practical experience, that the Dermapen with the retinol works better in the superficial texture. Also, like, I'm able to deliver other ingredients like exosomes and all of that. So,
Okay, thank you so much.
Thank you. The gentleman in the cap.
Thank you for presentation. Oral isotretinoin for a long duration causes, in some patients, atrophic scar. There is one contraindication for atrophic scar that is laser. How you will treat this atrophic scar? Having treated with
Oral isotretinoin? So the newer guidelines, the revised guidelines say that you can treat with moderate dose of oral isotretinoin. The only device contraindication, the dermabrasion, manual dermabrasion, and traditional fractional resurfacing. Your microneedle radiofrequency, non-ablative lasers, fractional ablative lasers are exceptionally safe with oral isotretinoin.
Yes, please.
Good afternoon. What is your experience of Dermapen with exosome smearing, or how would you modify it to deliver better results?
In my experience of exosomes particularly, I use it more as obviously a regenerative in terms of texture, shine, and pore improvement. This is my experience of using, just needling it with the Dermapen and applying exosomes. It just gives a better finish with open pores and textural improvement, but obviously doesn't work on deep scars.
I have one more question. How do you tackle patients who have allergy to topical anesthesia?
Like lidocaine,
Yes.
Prilocaine. So, yeah, I mean, I see very few patients. I've seen very few patients, but we do see a lot of redness on occlusion, which is common, which settles down. But I would like to answer, I don't have a lot of patients with allergy to topical anesthesia. Anybody in their experience, allergy to topical anesthesia?
Are you talking about an irritant contact or an allergic contact?
Irritant contact.
So irritant contact is common, and the best way to circumvent that is to hydrate. So if you use it on a hydrated skin, so you can apply, depending on the area. If it's a larger area, I actually use a jet. I use a jet with normal saline, which gives hydrobrasion. Then I use hyaluronic acid, which then helps to, it just gives a little bit of hydration to the overall skin. And then we apply a layer, a thin layer of the topical anesthetic, Prilocaine, lidocaine combination, and we apply cling film. So that helps with absorption, faster absorption. In 10 to 15 minutes, depending on the patient, how much they need, we remove the cling film, apply a second layer, and then massage it in and apply the cling film. In another 15 minutes, it's out. So within half an hour to max 35 minutes, you're ready to go. Don't keep it longer than that. And hydrate and put thin layers, occlude it better. You have a well anesthetized patient with minimum irritant contact chance.
The actual allergic part, we don't see that often. It's the occlusion and the irritation and the erythema that we see. That's
Thank you. Thank you, ma'am.
Yes, another question from the floor. Would you like to take the microphone?
Yes, doctors. I just want you to comment on this case that I had recently. She came to me for aquagenic pruritus, and then she also had scars on her face. And during her follow-up after 1 week, I remember she came with a microneedle post-treatment. And what do you think about patients having active aquagenic pruritus, doing microneedling treatment on their body? Can you comment on that?
I think it's totally fine. It's totally fine. I mean, are you asking me, should it be done or not? Yeah, you can absolutely go ahead and do it. And just tackle the aquagenic pruritus separately.
May I ask, are you talking about cholinergic urticaria or aquagenic pruritus? In cholinergic urticaria, patients will have to be a little careful because any sort of stroking of the skin may cause an aggravation of the urticaria. So you'll have to, and sometimes we see it after we start and we don't have that history. Sometimes, the patient doesn't tell you, or you may have also slipped in asking, or it pops up. So then in that case, you can give an anti-allergic, any blocker, a histamine blocker, before the procedure, as well as, say, 8 hours or 6 hours later, and cooling. But too much of cooling also is not good, because that itself can excite a cholinergic. So, and maybe have more reserved settings.
Yeah, yeah, exactly. Excuse me, do you want to use the mic? Yeah. So you can use that.
So when she came to me, we started with bilastine twice a day, and we also started with methylprednisolone. So when she had her microneedling, she was on those medications.
Which is fine.
Microphone.
You can give oral steroids, 10 milligram, say the morning of the procedure, 10 milligram right after, 10 milligram that night, or not at all. You can skip the post-procedure is important. And then you can see if she, and continue with the anti-allergics. So you can give anti-allergics 1 to 2 days before, the day of, 1 to 2 days after, and a short course of oral steroids, say 20 milligram for 2 days, should do it. But the patient should be willing to take the steroid. Yeah.
Thank you very much. And thank you to all our speakers. We're going to wrap this up now. It's 4 o'clock. Thank you so much for your attendance.
Yeah.